And you guys, if you kindly remember to mute yourself. So please mute yourself, huh? So we have more people. If you please remember to mute yourself. Please mute yourself, huh? Remember to mute yourself unless you have a question. Okay, we're 17 so far. We'll give 1 more minute, I will start. Okay, I think we start recording. So let me share my screen. Okay. So assessment, if you guys remember, assessment of newborn babies, a little bit different because the scope is different from examining a child or an adult. Because when we examine a child or adult, we have a purpose either to diagnose or to put a differential diagnosis or to assess. If you can kindly mute yourself. If you can kindly mute yourself, please. Yeah, Dr. Sudad, mute yourself, please. Yeah, Sudad, mute yourself, please. I'm muting you and you are unmuting. I mute you and you are unmuting. Sudad, mute yourself, please. Yeah, Sudad, I muted you 6 times now.
نعم.
Mute yourself, please.
أستاذ ده يرجع يعني هو من كيفه ما أعرف ليش.
Okay, I muted you again. Okay, so the scope of assessing a newborn is a little bit different from pediatric because when we examine an adult or a child, our purpose is either to diagnose or to Sudad, I cannot continue like that. Okay, so Ya Allah. Sudad, if you can log out and log in, please, again.
تمام.
Okay, so in adult we examine them to diagnose one, or to put a differential diagnosis, and sometimes we cannot diagnose. We just alleviate a symptom for support, or to prevent pain, or to answer a question. So that's the purpose of doing examination in adulthood. However, in pediatric and neonate, the assessment. Yeah, Shayma, mute yourself, please. Am I going to keep repeating the Manal, mute yourself? I'm going to keep this all over the day. Please mute yourself. Yeah, Manal, mute yourself, please. Dr. Mustafa, mute yourself. Yeah, Mustafa,
نعم أستاذ.
mute yourself, please. Huh?
إن شاء الله أستاذ. تمام.
Okay. Tamam. So the purpose of a newborn exam is to check for anomalies. That's one. To look for birth trauma, and to do screening, and to look for medical conditions such as jaundice or cardiorespiratory problem. So then one of the main important, also to support or to reassure parents for some innocent problem that you see in newborn babies. And so the purpose of a newborn examination is a little bit different from other examination, and the examination should be done within 24 hours. So usually what happens when the baby born, you have to decide whether the baby need resuscitation or not. If the baby need resuscitation, then you divide either the baby will need intensive care or intermediate care or monitoring care or does not need care. If the baby does not need care, you go with what we call it well baby care. The well baby care, there are many things we do. We do screening, we do circumcision, we do vaccination. Can you please, Mustafa, mute yourself? Jamal, can you mute yourself, please? Okay. So I'm keeping interrupted. I mean, the flow of them will be interrupted. So once the baby born, you need to decide whether this baby need resuscitation or not. And the decision to need resuscitation depends on NRP. So there are a few questions you need to answer, and a baby will need resuscitation or not. Once the baby needs resuscitation, then you have to decide intensive care when you need active resuscitation, such as giving pressure support or ventilation, or intermediate care, or sometimes what we call it monitoring care. So the baby responded to first few steps of resuscitation, but you need a monitoring care. Monitoring care means the baby does not need continuous monitoring, so you check the vital sign every 6 hours. But sometimes the baby does not need any care, or what we call it well baby care, or some people call combined care, when the baby with their mother. So you do a combined care for the mother and the baby. In this situation, you need to assess the baby, and the assessment usually should be within 24 hours. So what you look for when you assess, you look for congenital malformation, whether it's apparent or hidden, whether it's a major or minor. You need to look for innocent problem. Please mute yourself. Look at the bottom of your screen, and if your mic is not crossed, just click on it. It's not very difficult to be done. Mute yourself, please. You also need to look at innocent problems such as mastitis neonatorum, such as Mongolian spot, such as secretion from vagina, such as some of these innocent problems, such as cutaneous marmorata, such as birthmark. These also innocent problem you need to see. Zainab, please mute yourself. You need to see them and explain them to the mother. Okay. Now, part of the assessment, now the whole baby is the mother, so you need maternal, family, and history. And it depends how long the baby will stay in the hospital, but sometimes you need to repeat the exam. So if the baby stays more than 48 hours, you probably, Jamal, please mute yourself. So you might need to repeat the examination. Now, I'm not going to repeat all this, but you need a prenatal history. and obstetric history and family history, very important. And part of the newborn exam, you need to reassess or review your prenatal testing, the screening testing that the obstetrician does. And usually in the first prenatal visit of the couple, they do blood group and RH, they do rubella. Zainab, please mute. Zainab Hamid, please mute yourself. Rubella status, you need the syphilis screen. So please look at the bottom of your screen. If your mic is not crossed, just click on it. It will be muted. They do syphilis screening, hepatitis, urinalysis, chlamydia, look for gonorrhea, human HIV, and so on. Also, they look for thyroid disease, type, assess for presence of absence of diabetes, whether it's type 2 or it's a pregnancy induced, and some infectious diseases. In the second visit, we do more testing, such as screening for GPS for babies or for ladies pregnant with more than 34 weeks. They do screening for neural tube defect. You do ultrasound screening and so on. And then once the baby delivered, you need to do a delivery assessment. So you need to know it's a normal vaginal delivery, it's a C-section, there is leaking, there is no leaking, amount of liquor, duration of delivery, assisted or not, and so on. Okay. Now, part of your assessment within, you have to look at the resuscitation, and then you need to know whether one active resuscitation, when we say active, mean the baby need more than, there is 5 steps of the beginning. You do positioning, you do dryness. Koyan, Zohair, please mute yourself. So you need to, first 5 steps, which is dryness, warming, positioning, clearing of the airway, and stimulation. If you need more than that, then this is active resuscitation. So it's very important when you do the assessment to review the resuscitation, whether it's done or not. Remember that when the baby resuscitation was needed, then very important to remember to check sugar, to check the temperature. Okay, look if the baby developed apnea and establish the feeding. Okay. Now it's vital, it's very important, and keep this in with whole your life. You should not say term and preterm. That is incorrect. Term, preterm, late preterm, extreme preterm are very subjective terms and has no meaning in neonatology. You need weeks and days. It's not enough to say 36. You have to be 36 plus 0. So we know the days, and then because each day is count. So don't say when you present a baby, don't say that this is a term or a preterm. No, you have to say he's 36 plus 2 days, and today day 2 of life. So it's important to remember that to say that the weeks and the days. Well, remembering that when the baby is less than 37 weeks, he's a preterm, and between 34 and 36, he's late preterm, and when he's more than 37, he's a term. And remember that when babies are preterms, even if they are late preterms, they are prone to complications, and that's why the younger the baby, the less the gestation, the more possibility of readmission. So when you send the baby, there is something on the American Academy of Pediatric Neo Review is giving you the percentage based on the gestation and other risk factor. What is the percentage that the baby? So for example, if you send a 34-weeker home, the possibility that the baby will come back to the hospital is around 40 to 50%. Why? Because he might develop hypothermia, hypoglycemia, hyperthermia, apnea, poor feeding, vomiting, jaundice. All these might need, and baby might develop sign and symptom of sepsis. So it's very important when you send baby, or when you decide to admit or not, to remember the rate of readmission when you send the baby home. Also, you have to decide whether the baby needs sepsis workup or not. And remember, please, it's not septic workup, it is sepsis workup, because septic workup means Your workup is septic. Your workup is dirty. Septic workup means the workup is dirty. It's a sepsis workup, mean you're doing a blood workup for sepsis. So remember, there is when you have, can you please mute yourself? My goodness, I am getting fed up with this. Who's opening? I don't know how to control this. You guys are 25%. I cannot look at who is not. Dr. Zainab, you are not muted, please. Who's else? Okay. So please watch your monitor and your screen and see if you are muted or not. Now, when you decide to do sepsis workup, it's important to have two things to do the sepsis workup. The first is yes, yeah, Dr. Ali, I am muting everybody, but they return back. I know that. I'm muting them and they comes back. Thank you for the note. But yeah, I know I'm muting them. So to decide to do sepsis workup or not is you should have risk factors and symptoms. So if you have risk factors but no symptoms, you only observe 48 hours, you do CVC and keep the baby with their mom. If you have symptoms but there is no risk factors, you observe and treat the symptoms but don't do sepsis workup. So to do sepsis workup, you need symptoms, you need risk factors, and symptoms. So what are these risk factors? Mother is febrile, membrane is ruptured more than 18 hours for blood infection, and more than 4 hours for herpes. If the baby is premature, but when you say premature, is born by labor, not premature for C-section. For example, C-section done because the mother is diabetic. This is not considered a risk factor. But when the baby born less than 37 with active labor, then signs of Coriaminity, so foul smelling liquor, or positive, or uterine tenderness, and so on, or leukocytosis. If the mother is positive, group B is not treated. And when you say treated, the baby should receive at least 1 dose 4 hours prior delivery, and it should be ampicillin. Any other antibiotics giving to the mother is not considered treatment of GPS. Erythromycin, cefotaxime, clavuran, methoprim, all considered no treatment. The only treatment for GPS is crystalline penicillin or ampicillin. Any other antibiotics given by the obstetrician will not eliminate the risk factors of GPS. So if you have a GPS positive, but the mother received a dose of ampicillin at least 4 hours prior to delivery, 1 dose, then this is considered the GPS is not existing, it's treated. So how we do sepsis workup? As follows. We have risk factors plus signs and symptoms. Then you do sepsis workup. And please remember, it's not septic workup. Don't say that. Septic workup in layman language mean prostitution. And in medicine mean your workup is dirty. So it's sepsis workup. So what are the risk factors? Mother in labor. That's a risk factor of infection because labor can cause that. Prom more than for 18 hours. Fever, leukocytosis, tenderness, GPS positive, urine or vaginal swab positive, previous neonatal sepsis, previous death, fetal distress, fetal growth restriction, and symptoms. Symptoms are any baby who need more than simple first few steps of, so any baby needs stimulation, that is a symptom. Need PPV, that is a symptom. Any baby less than 37 but with labor, not prematurity due to C-section for maternal reasons, that's a symptom. Poor activity is a symptom. Hypotonia, abdominal distension, vomiting, hypoglycemia, temperature instability, tachycardia, bradycardia, apnea, seizure, feeding are all considered. So what is sepsis workup then? When we say sepsis workup, that does not mean the baby is sepsis. It is called in medicine to rule out sepsis. So when we say sepsis workup, that does not mean, because sepsis means there is bacteria in the blood with the symptom. So if there is bacteria without symptom called bacteremia, but if there is bacteria and symptom called sepsis. When we say sepsis workup, that means the term is to rule out sepsis, not sepsis. So what does that mean? We do blood culture, we do CBC. People do CRP, ESR, and procalcitonin. I don't do them at all. Never done them for last 2 years because they are makes of no value. So once you do sepsis workup, in my practice, I wait 48 hours. If there is no report, so I send blood culture and there's Dr. Pishdar Abdullah, please mute yourself. So if there is no report, which means I send blood culture to the lab, but lab didn't get back to me. Because remember, the preliminary report should come within 48 hours. The final usually comes within 25 days. So remember, in 48 hours, if culture still there is no report, that means the lab didn't call me that it's coming. The possibility that the baby has infection is less than 5%. The yield is 95%, especially if the baby is asymptomatic. So what I do is I give the antibiotics, I start to presume. And please don't go meropenem. You don't need, meropenem is not a good antibiotics. It's wrong. Don't go cefotaxime. It's not a good antibiotics. These are not broad spectrum antibiotics. You don't need to do that. It's ampicillin and gentamicin. These are the best antibiotics for neonatal sepsis. So I start ampicillin and gentamicin, depend on the person, on the gestation and the weight. And then I wait 48 hours. If the culture is negative, I stop the antibiotics. Now, some people, baby is symptomatic. Now, some people say the baby is symptomatic, but the question is, are you supporting the baby? So let's say if the baby in respiratory distress, are you supporting the baby or not? I don't know what to do. I'm going to stop the session. Okay, so I muted everybody. Let's hope nobody will open the mic. Okay, so you do the sepsis workup and give the antibiotics 48 hours. If you don't receive a report from the lab or the lab report, you stop the antibiotics. Now, some people say baby is symptomatic, but symptoms can be from other, the baby has not only sepsis, there are other things that end. So when blood culture is negative, that means there is no sepsis. Now, if you do the sepsis workup within 24 hours, then you need only one site. But if it's more than 24 hours, so let's say the baby is 36 hours and you do the sepsis workup, then you might need 2 sites culture. Especially if you have a central line to avoid, the diagnosis of contamination. Okay. So what do we do in sepsis workup? We do CBC culture, we start antibiotics, and if the baby is asymptomatic, we stop. Now, if we have risk factor or symptom and symptom, then you need only monitoring. You don't need sepsis workup. Okay, so you do, when you say monitoring, we keep the baby 48 hours in the hospital. It can be in a dependent area or with the mother. We do CBC and check the vital signs every 6 hours. Vital signs including temperature, heart rate, respiratory rate, saturation, maybe sugar, and so on. Now, if I have CBC result more than 30,000 or less than 5,000, I start antibiotics. So when I do CBC, or if the baby has symptoms, I start antibiotics. If the baby is not responding or not improving. Okay. So I did sepsis workup. If the culture is positive, I continue the antibiotics until I know the identification. And then I repeat the culture every 48 hours. And I continue antibiotics until I have 2 cultures negative 48 hours apart. So after 48 hours, and if the culture is positive, I repeat another one. And after 4 days, 6 days, I do another culture. 8 days, I do another culture until I have 2 cultures negative. Okay. And I continue the antibiotics depend on the type of bacteria. And of course, I will get the sensitivity and the location of the infection. So when I have osteomyelitis or meningitis or arthritis, is it different from I have UTI or I have pneumonia or I have a, just culture positive. So it's very important to decide the duration. And after that, I send the baby home. Now, if the culture is negative, culture negative. Now, it's very important to remember culture negative sepsis. It's very important to remember that culture negative sepsis is only 30%. So if you have 10 babies on blood and culture, you should have at least 7 of them positive. If you have 10 babies in the unit on antibiotics and less than 7 are negative, you are overusing antibiotics, because the culture negative sepsis is only about 30% of the sepsis. So usually in culture negative sepsis, I continue instead of 2 days, I continue for 5 days. And I also, again, I repeat the culture on day 4, just to make sure that the culture is negative and did not grow. So if 48 hours, another culture negative, I stop and send baby home. While in monitoring, I do these. And if there is any sign and symptom and there is, no CBC finding, no symptoms, I send baby home. If the baby monitoring develop more sign and symptom or worsening, I do sepsis workup and then I follow the same scheme. Any question about neonatal sepsis? Any question so far? Okay, and then we start to do, go ahead, please.
Actually, it's not about sepsis.
Yeah, go ahead.
It's about the routine physical examination or checking of the newborn concerning the Barlow and Ortonelli test for DDH. Is it still held? Isn't it traumatic to the hip joints?
Assessment of joint stability?
Yes.
Okay, so the assessment of joint stability should be a routine for all babies. And the term that you're using should be very careful, because some people want to say, I want to dislocate to see if I can dislocate the hip, which is incorrect. What you are trying to see if the hip is stable or dislocable. So I do not think it is painful, but you need to be gentle.
Not about being painful, being traumatic. Can it be substituted by ultrasound for the hip joint?
No, you have to do it clinical. I don't think should be traumatic. I don't think, well, anything can be traumatic. I can hold the baby in a traumatic way. But no, I think hip stability testing should be a routine screening, including red reflex, including femoral pulse, hip stability. These are, I think, medical legal, and well, let's assume it's traumatic. I think having a dislocated hip or DDH is more traumatic than examining the hip stability. No, I think you have to do it clinically, but even if it's negative with risk factors, you need to do ultrasound. Now, it's X-ray or ultrasound depending on the gestation and depending on postnatal life and depending also on the expertise of the radiologist. So no, I think you have to do the exam. Okay, so general exam. Now, this baby decided that this baby went home, went with mother, combined care, not admitted, not needed destination now. So the examination must be done with the mother. the examination should be done and the mother should be watching. The examination should be done and the physician or the pediatrician should be speaking with the mother that I'm doing this and this and this, okay? Should be in warm and quiet environment with very good light. And the most important is you observe the baby before in a resting position. Very important to look to the movement, to the position, to the color, and to the breathing effort. You need to do the measurements, including weight, head circumference, and you need vital signs. The vital signs, these are include the vital signs, including heart rate, respiratory rate, and saturation, maybe temperature, maybe sugar level, very important. So it's very important to do the vital signs. And when you examine, you need the examination should be part by part, is way better than doing systemic examination. I prefer it. And whatever the way you do should be a systemic, and you should stick to, and it should be followed by all the doctors in the hospital. So not everybody does the exam in a different way. And the reason is because the exam, please mute yourself, Aysar. The reason is that because sometimes the examination need to be done by more than one physician and in a different time. So if each use the same way of assessment, so there will be very systematic, will be very organized, and there is no missing. Yeah, Aysar Abdullah, I muted you now 3 times. Please, why you are re-muting yourself? So let's mute everybody again. So now from where to start, from the back to front, from front to back, from up down, from down up, it doesn't matter. It's the most important is you examine all the parts, part by part, and everybody should be follow the same way and same way of note writing. I start from head to the toe. Aysar, please mute yourself. Remember that you need to examine the hip, as Dr. Rehab was saying, and the spine is very important. Now, it causes lots of disturbance when you do the spine and the hip, but they need to be performed, and try to perform these tests that cause disturbance at the end of your examination. The examination should be for the hip should be done from the prone, but also from the supine position. The date of and time of the examination should be recorded, and this is very important to do the follow-up examination. Remember that some of their finding might be related to a transition period or related to the birth. Dr. Aysar, please mute yourself. Let me mute again, everybody. Okay, I did. Ya Aysar, mute yourself, Habibi Aysar. Akhuya al-Aziz. Let me mute everybody again. Okay, so it's very important to know the gestation by week and date, not using subjective terms, because these terms has different meaning for everybody. Okay, and the reason, because some of these signs and symptoms, especially the transitional one and related to gestation. When you inspect, please look at the movement, look at the position, look at the color, but also look to the sex, the gender of the baby, if there is a birth defect, what is the nutrition, whether it's restriction or not, respiratory effort, position, color, and so on. So these are, sex determination. You're looking to the genitalia, male, female. Look at the birth defect. Okay, identification of deformity, and the deformity need to be determined, especially the foot. We have the cavus, we have the adduction, we have the varus, we have the equinovarus, and the combination of all these. So these terms need to be known, and everybody should know, and everybody should use the same term. And when you write it down, you should know the meaning. Look at the birth defect. So we have the cleft lip, and it's very important for the cleft lip or palate. We need to know it's a unilateral, it's a bilateral or not, and is it cleft lip or palate? And if it's palate, it's a hard and soft, or both. It's very important. We need to look at the fetal nutrition. So look at the subcutaneous fat, and it's very important to look at the thigh and look at the cord. Look at the Wharton jelly of the cord. Very important to assess the nutritional status. And when it's over, remember the of macrosomia, especially diabetes. And when it's under, it's a fetal restriction. So it's very important to look at the Wharton jelly of the umbilical cord. Look at the respiratory effort. And please don't mix between respiratory difficulty and grunting. Do not use word grunting. Word grunting has a meaning, and it has a differential diagnosis. So grunting is not a breathing difficulty. And grunting is not mooning, baby. This is not grunting. Grunting is reverse of respiratory cycle. It's pausing after inhalation. It means the surfactant is deficient or being neutralized. It's not a breathing difficulty. It's not using accessory muscle. So please avoid medical jargon, saying words that you don't know. So please, flaring of LNASI, using of intercostal, subcostal, or supracostal muscles, the word grunting, okay, very important to remember. And you need the respiratory rate. And respiratory rate, please count it over 1 minute. Do not take it from the monitor or count it over 10 seconds. Now, 10 seconds or 6 seconds, we use it only during resuscitation because we need to make action. But during assessment, we need to check it over 1 minute. It's very important to know it's within normal, above or below 60. Okay. And please don't use word grunting for respiratory difficulty and for moaning. The baby is sick and tired. Grunting, moaning usually when you have low functional residual capacity. But grunting is when your alveoli is sticking due to absence or deficiency or neutralization of the surfactant. And please know the meaning of upper and lower airway. Please go, and it's not anatomical demarcation. It's a functional definition of upper and lower airway. And here is explanation of what's upper and lower and why it's important. So upper airway is a point where the outside pressure change from atmosphere to negative intrathoracic, and usually call it thoracic inlet. And the reason why, I'm not going to go details, it's a ventilation issue. It's because the air to move from one point to one point, that point, such as A, should be higher than B. And because of that, because of the presence of upper airway to atmospheric pressure, usually the symptom of upper airway happen during inspiration, while the symptom of lower airway happen during expiration. It's very important when you look at the position and movement to look for the symmetry or asymmetry. And it's very important to know that a baby adapts a position. We call it universal flexion. Very important to remember this. So every joint in the body is in flexion. And the baby should be able to take off the legs and the hands of the mattress. And that means the tone is good. And the baby should be able to move all the extremities. However, not able to move or only move one limb or deviation, that is usually abnormal. Mostly it's a birth injury. Now it's or deformation. Now it's or the baby adapting abnormal uterine position. Now it's important to remember, because there is a little bit confusion, that birth trauma always occur at birth. That is incorrect. Erb's palsy can delay. And the reason why delay, because in birth trauma, you have the primary insult and you have the secondary insult. The primary insult is damage, while the secondary insult is inflammatory response resulted from the primary injury. So maybe the baby is moving the hand, and after 48 hours, the hand starts not to move. That does not mean the first doctor who did the exam is wrong. And that does not mean that the damage happened post. It can be post, but remember, birth trauma sometimes are delayed. You need to look at the color. I'm going to stop here, actually. And next week, I will continue from this color assessment. Unless you guys have, I want to stop here. I want to look at you and I want to answer questions. So if you do have a question, please ask me. Anybody have any question? Go ahead,
Yes,
please.
yes. Doctor, about vision and hearing exam and Godry
Yeah.
test, is it easy to applicable for us, as example in Kirkuk?
Well, we don't call it Guthrie test anymore. It's a newborn screening, and a newborn screening is essential. It's very essential. Hearing test, before we use it for risk factors, but now it's a universal. So we do hearing test, and there are many types. There is the autoacoustic or Apgar. So, and remember that people are a little bit confused about hearing testing, because people think that when the baby pass the hearing test, that means he is hearing, and that's incorrect.
Yes.
When we say hearing test, what we do is we apply a noise and then look at the response. So the hair of the cell of the internal is moving. So what that means, that the hairs, the cell, the internal is responding to noise, but we don't know whether the child is hearing or not. But when it's responding, mostly the baby is hearing. But mama sometimes is hearing, but the baby is not hearing. So there is a response, but the baby might not hear. So remember that when we say pass hearing test, that does not mean the baby is hearing. So when we do ABR or auditory brain potential response. So hearing test is vital, because as you know that to establish language, you need to hear. And also there are other confusion when you tell the parent, does the baby hear? They say yes, and that's incorrect too. It does not mean that the baby is hearing that he will speak or he has no hearing problem. Because, for example, Ali hear R and I hear R. I hear it in a different way than Ali, because the pitch of the noise of the sound and the frequency that you hear is different from mine. And that's why there is some people say it's a musical ear. So people listen to music and they know music better us. Some people also smell perfumes better than other people. because the number of nerve ending they have is more than others. So remember, when you have language problem, you need to do hearing test, a formal hearing test, with or without baby ability to hear. You do not consider the parent decision that the baby is hearing, because again, the baby might hearing the letters in a different way than you. The number of decibels that the baby is losing might be different. And remember, some letters need very low pitch, and some of them need very high frequency. So for when you say these are need, but when you say r, okay, so it's very important when the baby comes not speaking to do hearing tests. You do not depend on your clinical assessment, and you do not depend on. So it's very important to remember that hearing screening, that does not mean that the baby is hearing. It means that internal ear is responding to noise by movement, but that we don't know if the brain actually hearing or not. So hearing test is mandatory. Newborn screening is very important. And now you can afford it or not, that's a different story, but it is, some people call it Guthrie, a misleading name from the Guthrie test that was done for phenylketonuria in 70s. That's been about 40 years ago. So now it's called NBS, or newborn screening. So screening is essential, actually. They are very important to pick up some metabolic diseases and other risk factors, risk-based screening, such as cystic fibrosis or other diseases. So screening, yes, and including hearing tests. And some tests are important, such as hip stability. So I do screening for hip by ultrasound at risk babies. Any baby who's admitted to the NICU more than 2 weeks, I do hip and family history. Clinically, the hip is not stable, abnormal position. All these babies, I do ultrasound screening. I do the hip screening at age of 45 days. I don't do it early. I think early is a little bit misleading because of the stress of the labor and consequences of labor on the baby. So usually if the baby is admitted to a hospital and discharged before 45 days, we give appointment as an outpatient to do. And now you can do ultrasound or you can do dynamic ultrasound. Now I think after 3 months, probably I would order X-ray other than ultrasound for the hip. Any more questions? Any more questions? Ahmed Ibrahim, please mute yourself. Any more questions? So next week, we will do the continuation of this newborn assessment. I think it's very important to deliver a few messages to you all about proper, and please, if you want to practice neonatology, don't practice neonatology based on Nelson or any other textbook, because that is neonatology from pediatric point of view. So you need to use neonatal books at least, or subject appraisal when you read. Any more questions, please? No? Anything? Okay. So I think for today's short session is very good. I hope that you guys review what we did right now. And inshallah, next week we will do the color, start for color and continue the newborn assessment. If you guys have no question, I'm going to stop the session. Oh, Tidallal Dr. Muhammad, thank you very much. Alaykum assalam wa rahmatullah. But I would love that to hear questions, because the questions are very important for me to explain. So use the opportunity and ask me.
دكتور يحيى لا تسمح لي مو question بس من جوابك لسؤالي يعني اللي احنا اللي نسويه بالنيونيتال بيريد هو اوديتري ريفلكس اكزام الافرنت والافرنت مو الهيرنج اللي هو نحتاجه بعدين. وانا اللي اعرفه يمكن على مود الكوكلر امبلانت اللي اقل من 5 سنوات مو صحيح كل ما
تمام.
ايرلي دايجنوسيس للدفنس فهو جود بروجنوسيس.
Yeah, I agree with you. When it's
no.
positive, when fail, need for full auditory assessment.
بالضبط.
Usually when baby fail, we review. But what I was trying to say, when it's positive, that's mean pass. That does not mean the baby is hearing. That's what I'm trying to say. So when fail, you need to repeat. If fail again, you send the baby for formal audiology assessment. But when the baby passed the hearing, that does not mean the baby is hearing. That's what I'm trying to say.
Yeah, right. Another question that اسمح لي دكتور بالنسبه لي قلت لي هو ما نسميه جوثري بعد اللي احنا قاريه بالتكست انه هو روتين وسمبل بس اللي حضرتك قلت لي عليه هو نيوتال سكرينينج اللي هو اعتقد ما اعرف افد 400 ديزيز واكسبنسيف. فانا اقصد شنو اللي نقدر نسويه كروتين وكسمبل ونون اكسبنسيف واحنا اكيد اذا تشك بفد شيء اكيد راح تدزه على يعني تحليل متقدم.
Well, first is not 400. It depends on how much you pay. So it depends on the system we're using. So what we do is we do the filter paper and we put 4 drops within the circle and then you fill the information. And why it's dropped? Because it's dried and you can send it by mail. So if you don't have lab, you can send it somewhere else. It depends how much you pay, and they do. So there is like there can be 4 diseases, can be 6, 8, 12, 16, 24. It depends on how much you pay and what is the prevalence in. So there are the amino acid diseases. There is the FAO, the fatty acid oxidation disorder. You have the galactosemia. You have the thyroid. You have the TSH. It depends, TSH or hormone, depend which one. And other test is you can add more tests, such as storage diseases, such as rare other diseases. So the metabolic screening, the number depends on how much you pay and the cost. Now it's a whole system because most of the screening use chemistry, other use tandem mass spectrometry or gas chromatography. It depends on the way you're using your screening. So now how you do it, you have to buy the system, unfortunately. Or if you cannot buy the system, you have to be part of other countries' programs. So if there is a program in another country or another institute, you can be involved. You do your filter paper and send it to them, weekly or monthly, and they do the screening and then they get back to you. So there is no other way to do metabolic screening, including the amino acid, because we used to do phenylketonuria, but now you have to use all the amino acidopathy, whether it's the branch chain amino acid or it's acidemia or whatever the diseases.
اشترك دكتور بالضبط جانا عرض من شركه سانوفي على موديل بومبي ديزيز قالوا هم فريلي يجوزوا ما اعرف للنمسا او اي دوله. شنو رايك به؟
نو هذول تجار ما لك دخل فيهم هذول
كيفنا فرحنا.
they do it free because the expense of the test is way less than the amount of the money that we'll get when they start to send you the enzyme replacement. Okay? And the enzyme replacement is a governmental sponsor. So, and remember, this baby might need the enzyme the whole his life. So they got very good money. This is part of business. I don't think this is like a volunteer or a humanity or whatever you name it, but this is a business. They do that because when they get I think they consider the following, that what is the number of the tests that they do per year, and what is the pickup rate? So how many babies they got per year and how much they have to get money from each baby. So I think it's a business other than anything, including the company. Yeah. I'm not saying it's wrong. I'm not saying it's wrong, but
it depends on whatever available.
Yeah, I don't think it's wrong, but they're doing it for business.
Thank you very much.
Thank you. Most welcome. Any more questions? No? Nobody want to ask question about the board trainee? You don't have any question about newborn period? You don't see anything in your babies that you need to ask about? So let me ask question then. What is Apgar score? Anybody want to answer me?
Evaluation of resuscitation.
Evaluation of resuscitation. No, Dr. Ali. Yes and no, but it's no. Anybody knows? I mean, what is Apgar score? No? كلكم على الحياة؟ Nobody? 27 واحد ولا واحد يقدر يحكي؟ What is Apgar score?
Dr. Yahya.
Go ahead.
So yes, so it's 5 things you assess to see the response of the baby to your whether the baby needs resuscitation or not and requires active resuscitation for example, maybe.
Well, it is 5 things you assess, that correct, but it has nothing to do with resuscitation. Well, that's very important to remember, that Apgar score has nothing to do with resuscitation. Okay, so Apgar score is invented by Virginia Apgar, because some people think that it's an abbreviation. No, her name is Apgar. Okay, and she passed away like 5 years or 6 years ago. So it assesses few things, and it's only for documentation. It is about retrograde assessment of the scenario. It has nothing to do with resuscitation. It has nothing to do with the decision to resuscitate, the decision to start resuscitation, and the decision to stop resuscitation. Apgar score has nothing to do with all of that. Apgar score is a way to assess the baby performance during newborn period, with or without resuscitation, or retrogradely. So when we know the Apgar score is 5, we know that baby is not. So you need to continue do the Apgar score at 1 minute, 5 minutes, 10 minutes, 15 minutes, until you have the reading more than 7. So as far as 8 less than 7, 7 or less, you continue count. Once you reach, sorry, less than 7. Once you reach 7, you stop. Or the baby admit to an ICU. So you continue 1, 5, 10, 15, 20, 25. You keep counting until you pass 7. Yeah, 6 becomes 7, you stop. Or and that will tell me, you know, help me in the prognosis, help me in the documentation. So it's a method or a procedure to document the performance of the baby in the newborn period. Okay. And please, when you do the Apgar score, avoid Apgar score 10. Don't write them. Go ahead. Any question?
Dr. Yahya, you mentioned that whenever we reach Apgar score 7 or more than 7, we stop assessing. From a medical legal point of view, should we continue up to 30 minutes after birth, assessing and documenting? So
you need to assess at least 2 numbers. So 1 and 5, this is essential. But after 5, if it's less than 7, you continue. Once you reach 7, you send. So you can you do it at 10, at 15, 20, 25. Once you reach 7, you stop. Because at that time, that means the baby, when it's 7, usually the baby does not read resuscitation. And Apgar score is the way you document, or you tell when you do your assessment, or you do you're telling Dr. Yahya that this baby was in a bad condition, and this baby needed active resuscitation. But after the active resuscitation, Apgar score improved. So the Apgar score was 3, 5, and 8, which means the baby condition at 1 and 5 minutes was not great, but at 8 is improving. Also, the Apgar score at 15 minutes have a neurological prognosis, but at 1 and 5 minutes has no prognosis. So it's very important to continue. But the medico-legal issues always link to the standard of care. And the standard of care say you have to do it at 1 and 5 minutes, and you continue doing it as far as it's below 7.
Dr. Yahya,
Yes, sir.
about the prognostic value of the Apgar score, does it have any prognostic value? So let's say at 5 minutes, the Apgar score was 3.
No, at 1 and 5 minutes has no prognosis.
No
It
prognosis.
just tells, yes, it just tell you that the baby that time needed help. And at 5 and 10 minutes, it tells you the baby responded to resuscitation or not. But the Apgar score at 15 and 20 minutes has a neurological consequences. Yes, when it's a poor, you probably have poor neurological outcome. Okay.
Oh, okay. Perfect. Okay. Thank you.
Any more questions? Okay, we'll see you next session then. Okay. Bye bye.
Thank you very
Assalamu
much.
alaikum. Bye bye.
Thank you.
Assalamu
Goodbye.
Thank you.